I am Evian Gordon. I'm the founder of My Brain Solutions. I'd like to share a few insights with you in the next few minutes about how clinicians use this platform in their daily practice. The platform is an integrative approach to assess the brain, the key emotional and cognitive capacities, provide a report that then points to aspects to train new brain habits. The assessment is then redone, and so you can monitor the extent of success. The basic theory that drives the assessment, training and monitoring is the recent neuroscience evidence that emotions, non-conscious emotions, are driving our conscious feelings, thinking, and self-control. The components of the assessment, it's a standardized assessment that is relatively short. There's a 15-minute and a 30-minute version, and it taps, it assesses, it triggers the key aspects of emotion awareness, emotion recognition, face recognition, and the standardized, well-established aspects of cognition: memory, focus, attention, planning, executive function, sensory motor aspects of decision making. So once the clinician's given the patient their ID code, they go to a clinical portal, they do the assessment, then within minutes they get a report, and the clinician gets a report as well, a clinician version of the report. And the report is a very summarized view of the person's strengths and limitations, their emotional and their cognitive key capacities. Essentially, it's a profile. The platform is underpinned by the largest standardized database in the world, and it's essentially bringing together pretty much everything that you can measure about the brain, from cognition to genetics, electrical brain function, MRIs, DTIs, fMRIs, a whole range of demographic questionnaires. And the point of it is that we can uniquely drill down to make the most sense of those scores that are in this standardized assessment and in the platform. There are over 300 publications in the database, with about 300 scientists from many of the major institutions around the world. And the other aspect of this database is to, in one standardized system, pull out what are the key markers in each disorder. So for depression, the key marker is negativity bias, magnifying threat. In addiction, it's craving. In ADHD, it's of course sustained attention and the inability to complete tasks. And we have those insights for all the major psychiatric disorders. The database then provides a distillation of, for example, the cognitive key findings in each disorder. So for example, here in depression, this is 1,000 patients who we can see their negativity bias is very magnified. We in fact haven't found a single patient who doesn't have a negativity bias score that's extremely high. So they're magnifying threat about themselves, the world, their relationships, their work, very highly. And a number of other cognitive deficits, because in depression, the clinicians, of course, are looking at not just negativity bias as a marker, but also when people have any cognitive deficit, any thinking problem, memory problem, they do worse. And so that bifurcation, cognitive deficit or not, is very integral to the way, as you know, modern day clinicians would use an assessment. But in the depression report, we also have the PHQ-9, and clinicians reconcile the clinical symptom profile with the cognitive profile along the lines I summarized. Same idea for people with addiction. There are 10,000 people who've been treated using this platform, and the key marker there we have found is self-regulation and inability to self-regulate, particularly during times of craving. And so there's that marker with the red arrow, and then when the clinician gets the report, the markers have also now been elucidated to show when they're going to have poor response associated with too much anxiety and recidivism, those people who drop out of programs, and it's inevitably due to poor self-regulation. So it allows the clinicians to identify those people who have those markers and better adjust, better personalize their training program. Same for ADHD. For ADHD, the key markers there are, in addition to the obvious ones of sustained attention, we're seeing the inability for task completion, but also response variability. So there's something about that inability for speed and accuracy, that variability, that's another factor. And then, of course, an increasingly known fact is that about 20% of people with ADHD also have very high anxiety, and they're a separate subject. So that's the assess and the report, and the simplicity with which that report can be utilized, and intervention programs personalized. In addition, the report suggests which training modules, online digital therapeutics, we have about 30, are appropriate for that particular individual. I'll just give the 3 examples that I've been focusing on. For example, in depression, the focus would of course be the cognitive behavior therapy tool, which is called Thought Tamer. In addiction, we found that people with addiction train positive affirmations. So we have a positive affirmation app, amazingly more than anything else, orders of magnitude more, and that of course fits in very nicely with the 12-step program. And in ADHD, they of course primarily focus on the attention tools that will also encourage them towards task completion, in addition to ignoring distractions. So at the end of about 4 weeks, we usually recommend the second assessment, a redoing of the assessment. Although there's a lot of information, you can also tell in monitoring a person, a client, by their scores of what they train. So those are the small needles, but the big needle is, do they shift their emotion, their feeling, their stress, their thinking, and their ability to self-regulate. Here's an example with patients with depression. This is 1,000 patients, unmedicated, before and after treatment with one of the 3 most commonly used antidepressants in the world. Now the dark green is the patients at baseline, and the light green is after remission at 8 weeks. This is probably the most extensive study that's ever been done in depression, in cognition, and in fact it's been an integrated study for genetics. This data is likely to be the first test in psychiatry. We'll see, but certainly it's used currently. Just from these insights, you can see the negativity bias in the dark green, how much it is reduced in people who remit, and many of the other aspects of cognition and emotion as well. This frame of reference with respect to what works for antidepressives can also be used to see the extent to which it's effective in CBT or in any other depression intervention. That's the essence. It's a platform to assess, train and monitor, and it's really ultimately fulfilling one overarching goal, which is that if you can't measure it, you can't manage it.